today's CME code, which I'll put in the chat section in a minute. A little COVID update. This is US cases of COVID. This is North Carolina. As you can see, we're kind of hitting the dreaded plateau where the vaccination rate and social distancing and masks have done some good, but new strains are starting to pop up, which means people still need to be careful. This is the percent positivity in the Duke system. Less than 5 is considered pretty good, and for the most part, it's pretty good. Do people know what this spike is? These are the Duke undergrads and their bad behavior, which resulted in the Duke lockdown. And this is the number of admissions to the Duke hospitals, which is steadily going down, but it's still over 100 in the 3 hospitals with, I believe, about 30 people in the ICUs and 3 on ECMO. So it's still a serious situation, and be careful. Dr. Andy Liu is our all-star, and he is, his praises are being rang by Deborah Rose, one of our first-year residents, describing Andy as an incredible mentor, and I think we all know that that's true. A welcome to Sarah Parker, who's going to be working in the ALS clinic, both as a provider and a research coordinator. So welcome, Sarah. And another welcome for Ovi's young son, Zach. A little cutie pie there. I don't know if that's Ovi's first or not, but welcome, Zach, and welcome back, Ovi. A little research news. Simon Gregory, Chris Eckstein, and James Garaputo published a paper on neurofilament light chain and glial fibrillary acidic proteins as markers of progressive MS. And Ying Zhang was once again the lead author on a paper looking at patients with COVID and stroke combined, and found that they had a poor outcome. So again, I'll enter the CME, and now I'll turn it over to Caitlin Clark, who's going to do our case today. Caitlin? Oh, I have to hit stop share. Okay.
Thank you, Dr. O'Brien. I appreciate the opportunity. I'm going to share my screen very quickly. Sorry, guys. And come on. Here we go. All right, so I'm going to present a case briefly. We have a 72-year-old woman who presented to the Duke emergency room on the 6th of February, 2021, with altered mental status as a level 1 trauma after a fall in the shower. There were no witnesses to the episode. When she presented, she was unresponsive. Her GCS was between a 3 and a 4, and she had sonorous respirations. She was hypertensive, and she had asymmetric pupils noted on exam in the ER. At the time, she was also noted to be bradycardic, and so the ED noted concern for Cushing's reflex and intracranial hypertension. At that time, she had a normal glucose, and she was taken to the CT scanner, and following that was admitted to the neuro ICU. This was the first image that was obtained from her CT brain level 1 trauma. As you can see, she has a very large right MCA territory intraparenchymal hematoma causing midline shift and probable ankle herniation. This was a follow-up, a scan obtained at the same time, CTA, that showed a likely right M1 aneurysm. And just something I want to point out, normally these will present with a subarachnoid hemorrhage as opposed to intraparenchymal hemorrhage, but it can present with either. So what happened to this patient? Neurosurgery was consulted in the emergency room. She had a very poor exam, and based on that exam as well as the imaging, they made the decision not to intervene either with surgery or with an external ventricular drain. They recommended goals of care discussions with her family. Over the course of the next few days, she progressed to brain death, was declared dead on the 10th of February. So really quickly, I'm going to talk a little bit about determination of brain death. So the first thing is that you have to ensure that there are no reversible conditions that could confound your diagnosis. The patient has to be normothermic. You have to have normotensive blood pressure using vasopressors as needed. You have to make sure that your patient does not have any pharmacologic paralysis on board. And so you would check a train of 4, which is basically attached to the skin using stickers, and it allows you to check for presence of pharmacologic paralysis. You also have to make sure that there are no sedatives or CNS depressing medications on board. And if the patient has received sedation or any other medications, you have to wait 5 half-lives at least for the drug to be out of the system. And from my experience, feel free to talk to the pharmacist if the patient has any confounding conditions like renal failure to help you determine when those 5 half-lives are. You also want to make sure that there are no outstanding metabolic derangements for these patients. Secondly, you need to have a neurologic diagnosis which explains the cause of brain death, in this case, the patient's aneurysm and large hemorrhage. You also need to have a clinical exam consistent with brain death. So for this clinical exam, you need to have evidence of coma. You have to have absent pupillary reflexes, meaning people should be fixed and mid-sized or dilated, not pinpoint. You should check oculocephalic and vestibulo-ocular reflexes, which we refer to as doll's eyes and cold caloric testing for the absence of extraocular movement. If the patient is under C-spine precautions, you cannot do oculocephalic testing. And if the tympanic membrane is compromised in the setting of trauma, you can't do the cold caloric testing. You can check a corneal reflex, which should demonstrate no eyelid movement. And you can check for noxious stimuli, which should produce no movement except for possible spinal reflexes like triple flexion or the Lazarus sign, various other spinal reflexes. Also, when you check gag and cough, those should be absent. Once you have that exam that is consistent with brain death, you proceed to confirmatory testing. The primary mode of testing is apnea testing. What you're looking for is a PCaO2 rise of greater than 20 millimeters of mercury above any chronic baseline hypercapnia, or greater than or equal to 60 millimeters of mercury in people who don't have a baseline hypercapnia. At Duke, we have a process where we draw an ABG, we manually ventilate using a mixture of 10% CO2 and 90% O2. We measure the end tidal until it reaches 60 to 70. We draw a second ABG to confirm that we have a correlation with that end tidal. We then watch the patient for 2 minutes to make sure that they don't have any respiratory effort, and draw a third ABG to confirm that the PCO2 has stayed elevated. This is not a practice that's utilized universally, and I should also point out that nothing that I have previously mentioned is standard or universal across the United States. There is no standardized method of brain death testing. If you cannot do the apnea test in a patient who is unstable, you can do digital subtraction angiography, radionuclide studies, looking for cessation of flow. At this time, CTA and MRA are not recommended as confirmatory tests because there's limited data on sensitivity and specificity for these modalities. And then at least here in the Duke system, just for the residents who are listening, just make sure that CDS is involved if you have a brain death declaration that's imminent. And that's all I have for everybody. Thank you guys for letting me present, and I'm happy to answer any questions if they come up.
We'll put them in, Caitlin, thank you. We'll put them in the chat section. So that was A, wonderful, B, exactly on time. So congrats.
All right, well, thank you.
All right, Andrew, and Andrew Spector is going to introduce our Grand Round speaker.
Yeah, thanks, Rich. Good morning, everybody. Welcome to another round of our Diversity Inclusion Grand Rounds series. Today, I'm very pleased to welcome Dr. Christopher Lunsford, who is a physical medicine and rehabilitation physician specializing in pediatric rehab medicine. He's the co-director of the Cerebral Palsy and Related Conditions Clinic at Duke Health. And his research includes cerebral palsy and spinal cord injury interventions, disability advocacy, virtual reality assisted therapy, and rehabilitation care coordination. He has a background in philosophy from his undergraduate work, and then went on to med school at UNC Chapel Hill, went to residency at UVA, and then fellowship at the University of Pittsburgh. And I asked him to come speak because a lot of times when we talk about D&I, we spend a lot of focus on race and gender as the sort of signposts of diversity, but disability needs to be factored in as well. And he's going to talk about how to make sure we are conscious about disability as we practice medicine. So, Dr. Lunsford.
Thank you very much. I sincerely appreciate this chance, Dr. Spector, to come and talk to you all. And I hope to leave some time at the end for questions, but I do have a lot to cover and I want to really challenge you all. So I'm going to share my screen here to get the slideshow. And if Andrew or Will can just confirm that the slideshow looks active.
Yeah, you look good. You're good.
Okay, perfect. So thank you all again for the chance to come speak to you. I'm going to talk to you about a term that me and my co-authors use, disability conscious medicine, that is fairly a novel way to approach this. And it really is to elevate what might otherwise be disability competence training, and to also elevate it past the idea that this is something that just needs to be a medical school elective or even requirement, that it will not succeed for us to help those with disabled lives. And if we do not help it go to training, education, and practice. I do want to take a moment to say that if I'm giving probably your first D&I talk after the tragedy in Atlanta and now the tragedy in Colorado, but specifically when we think about what motivates these sort of killings and mass murders, it really is sad that we live in a situation where we are needing catchy phrases and hashtags and acronyms like BLM to promote diversity and inclusion. But I'm an anti-racist ally, and I hope you are as well. And I think we all should be devoted to learning more about intersectionality and trying to help. I would venture a guess, I can't see everyone's video, but I think this talk is in this group is probably predominantly white, and if those who are of Caucasian background don't take a stake in this, we're in trouble. And I also want to apologize for giving Grand Rounds in a t-shirt, but today is a special day for us here in our clinic. It is Cerebral Palsy Awareness Month, and today is our Cerebral Palsy Awareness Day of the month, where after this, I'm going to see my patients all day. And all 25 members of our team here at Lennox Baker are wearing these shirts. And so I wanted you guys to be aware of that as well. And so I have some heady objectives here. I want to really ensure that everyone on the call appreciates that disability is diversity, or disability in the lens of diversity and inclusion, and recognize disability bias and ableism for what it is and how it affects disabled lives, and how it results in not only the healthcare disparities, but that those disparities have resulted in a significant divide between disabled communities in medicine. And at the end, I'll try to give you some tools. I won't just hopefully depress you. I'll try to give you tools of how to address and reject ableism that is affecting your patients by talking about disability representation in medicine and promoting disability consciousness, as we talked about at the beginning. Again, there are things here that I think it's important to realize that I'm speaking to a diverse group. Some people may have not even heard of ableism before. So please stick with me. I think I'll be able to hopefully catch everyone at where you're at. So for the disability health disparities, this is what you might have expected me to talk about. Honestly, I'm not going to reread this slide. These are disparities. These are based on research. These are important. But this isn't the problem. The problem isn't, do we need to figure out more of these sorts of facts? You know, this is a visual representation of disability-related healthcare disparities. And these Venn diagrams are scaled to fit the actual numbers. So nearly 1/3 of people who have a disability live in poverty. So that's the bigger circle. But surprisingly, maybe to you, 2/3 of people in poverty have a disability. And this doesn't, of course, include mental health, but that blue circle should really strike you that this is a very impressive identity related to those two Venn diagrams. So what I'm also going to ask you to think about is that disability can actually be positive for identity, because if I convince you of that, then I think the argument of disability being diversity follows from that. And so this is a picture of me. This is a very personal journey that I have been on, and I have a hearing impairment. So as we might say, it's a moderate to severe sensory neural hearing. And I put ... because when you look at me and you think about the thoughts and feelings that my parents had for me at this age when they decided I would be a cowboy, or maybe I decided, I'm not sure, do you really feel like the words that they would have used were, this child is impaired, or this child has a deficit, or this child has a loss? And I understand we have to choose language. You've already heard me using disability as an adjective, and all of our journal papers tell us to do that. No, we have to say people with disability. But when you do that, you take it away from being an identity former. And some people want it to be a part of their identity. So they are disabled people. They live disabled lives, and they think that that is not something to shy away from. So if it is a positive part of my experience, and is one of the reasons I'm now here giving you a grand rounds on this topic, then why not have it be part of that, but also needing to reevaluate these words. And it is, again, personal, because this is my son who also has a hearing impairment. And prior to him being born, we had no idea that my impairment might have some sort of genetic underpinning. And his mother is Vietnamese American. So we definitely, whatever I have did not come up on basic testing, and but still did get shared with him. So I am a disabled physician, and I want you guys to understand that there aren't many of us, and especially physicians who were disabled at the beginning of medical school. And unfortunately, that's by design. Medical school is made for one type of person, and people with disabilities are most often cut out of that. The vast majority of physicians with disabilities obtain their disabilities after they were physicians. And so we have, once they are physicians, they're really encouraged to stay in practice in some way and share their knowledge with the world. But yet we have a bias against letting people who are disabled before medical school start that training. And I just want to say that the scholars that have been and mentored me in my life have made this possible. I may have a philosophy background, but I was completely unaware of this world until I finished medical school, residency, and fellowship. It was only after I started practicing and being a part of the University of Virginia group, who is on the university side, having a disability advocacy committee, that I completely opened my eyes to how even I, as a disabled person, was taught to wrongly ignore that part of my life. And so I again ask you, is this really an issue? Might be a question that you have. And I really want you to take the red pill here from the Matrix analogy of find some truth and try to see if you can see past what might seem like, oh, this hearing impaired person has a very mild disability and is earning, using this mantle. No, it is the opposite. By not having identified as a disabled person in my whole life, I actually missed a chance to advocate and help the disability community in a way that I've only been able to do in the last 5 years of my life. And so as we go through this, I also like people to understand you got into medicine, I know, for quote unquote the right reason. You took oaths, and I don't remember for sure if I took the Hippocratic Oath or the Declaration of Geneva, but when you look back at a recent study, it looks like still it's something like 40 and 50 and then 10% other. So you took these oaths, and I pulled away that you might have said something along the lines of, I do not treat a fever chart of a cancerous growth, but a sick human being. Remember that, and that prevention is preferable to cure, of course, but there's no mention of what if you can't prevent or cure. And we need to really dig into that a little bit more and how we treat people who we can't prevent or cure. And then in the Declaration of Geneva, the last dated in 2017, we're going to respect people's autonomy and dignity. Perfect. But just be careful not to conflate autonomy with independence, because in our society we have, and autonomy is not the same as independence. And independence is an ableist and might I say capitalistic idea to value. And obviously, we will not violate human rights and civil liberties even under threat. And I think you have to remember that medicine has played a very important role in the history of people's human rights, and has been on the wrong side of that. And we even today are, sorry, I forgot to click that one. Even today, we are at a bridging point that I'm really quite worried about where we will go from here. So treating disability is not fixing broken people. Again, I almost have a shock statement here in order to help people consider reframing how you understand curative versus therapeutic medicine. Curative medicine is very good, efficient, and we have been taught to do the efficient thing. Therapeutic medicine is very messy and inefficient, and we start to dispose of what we might consider a waste of time trying to get into the nitty-gritty of something that we don't necessarily have the research to back up what we might do. It could be where you think about the science of medicine versus the art of medicine here. But I maintain that treating disability, which is what a big part of my whole career has been, and what physical medicine and rehab often focuses on, is yes, it's function, but function is defined in a subjective way, and that improving quality of life, which is clearly subjective, should be done while dignifying and respecting the impact of disability on a person's life. And that dignifying is a real part, because disability rights are human rights. And so when I talk about a divide between the disability communities and medicine, this is another time where I have many physicians ask me, is this really an issue? I don't really think that anything we're doing in medicine is infringing upon people's disability rights. And I've also had people ask me, you don't really think of yourself as disabled, do you? And they are conflating again this understanding of disability as getting social support for your disability, or getting disability payment and being somehow unable. Well, that's ableist to say that that they're asking, you don't think of yourself as unable. No, I don't think of myself as unable, but I do think of myself as disabled. And in terms of the disability rights movement, what I have noticed that we have this divide and there is tension that's growing. So with COVID, there's this story of Michael Hickson, who contracted COVID around June of 2020 and passed away, but there was significant concern around his passing that the medical team that he was with was not listening to the family. And I'm going to risk playing the short clip from this if it will play. And then again, Will and Andrew, let me hear if you guys are hearing this.
At the beginning of the pandemic,
Did you hear that?
Yeah, we did.
Okay.
a federal
I'm
civil
going
rights
to go
office
straight
warned
to
states,
one
doctors,
part
and
here.
hospitals, don't place elderly or disabled people at the back of the line.
Nursing home, back home, and then back to more hospitals and nursing homes. On that day at the hospital, Hickson found her husband's doctor in the hallway. He told her, "We're going to stop treating your husband and move him from the ICU to hospice care." This is from a recording of their conversation.
The decision is, do we want to be extremely aggressive with this care, or
The doctor is explaining, do we want to be extremely aggressive with this care, or would it be futile?
as of right now, the quality of life, he doesn't have much of them.
The doctor says her husband doesn't have quality of life, and If we have to intubate him, put him on a more powerful ventilator, in his weakened condition, he's not going to survive. That didn't make sense to me.
So, and I always tell people with this situation, I'm not entirely sure that there was anything specifically medico-legally illegal that happened here. The other part of this case is that the decision making for the patient had already been transferred to a third party. But it's concerning, and the language is concerning. And when you talk about where are we going with the future of our medical treatment, we have to remember that disability and managing it is certainly important, because it does come with health impacts, but that some of those health impacts are societally related, and that the understanding of someone identifying with a disability is not the same as having a illness identity or a Munchausen by proxy, but that is a very positive way to experience the human condition. And because of de novo genetic mutations, there will always be disability, or because of accidents, there will always be disability. But yet, if we get into this idea of gene editing for designer babies, then we really are just going down the train of eugenics. And so what I want to say here with understanding some of this is that you don't have to take my word for it, or this one anecdote that I told of Michael Hickson. The recent hot off the presses 2021 article from Lisa Ianezzi is that physician perceptions of people with disability are somewhat negative. We have in this survey of 714 that included 6 disciplines, including neurology, over 82% reported that people with significant disability have worse quality of life than non-disabled. 41% said that they were very confident. They were not. I think somehow a not got out there. Not very confident. Oh, I apologize. No, it is only 40% that they were very confident to treat people with disability, meaning that 60% were not confident. 57% strongly agreed that they welcome patients with disability into their practice. So again, not barely over a majority. And only 18% strongly agree that the healthcare system often treats people unfairly who have disability. So as you go through those, and again, for some reason, when I'm clicking on one part of my screen that's not going through, I'll try to be better about that. So I'll give you a chance to skim those and can get my slides to you later. So I'm gonna go a little quickly through these, which is, again, ableism is akin to racism. It is a well-researched, a scholarly topic that you can find many papers on. And yet, I think we just don't think about how it affects our practice and what we do. So the centering and domination of the non-disabled experience and point of view. So that is just like racism is the centering and domination of the white experience and point of view. And the idea, even if it's subconscious, that people with disabilities as a group are inferior to non-disabled people. So this is what we are working against. And it's important to remember that ableism tells us that it's part of human society, human evolution has always depended on interdependence. And at some level, this idea of being independent has developed, again, maybe out of a capitalistic society, that we all need to be self-sufficient, because that's easy for someone to make money off of self-sufficient workers. But no one does their own dental work or cuts their own hair, as Stacey Milburn Park has said. We all need support, and hierarchy of what support is okay to need and what isn't is ableism. So I have this example of ableism in medicine. There are plenty of examples, but I'm a rehabilitation doctor and I work with therapists. And again, even us therapists and rehab doctors are not free of ableistic tendencies. And so let's consider you have a child who is 5 years old, has never walked independently yet, and they say, I hear someone in the room, or we're all working with them, and say, let's work hard today in therapy. Oh, you won't be able to walk someday. Don't you want to walk someday? And that's a motivation technique that we are trying to really kind of help that kid have a good day in that 1 hour of hard therapy. Unfortunately, if you really think about the language that we just used in that innocuous statement, that's a threat of persistent disability is being used as a motivator by otherwise disability positive people. And that threat, when you follow it to its conclusion, translates to you are only valuable if you can walk as an adult. And if you do not walk, it will be because you did not try hard enough and failed. So that's a lot to put on a child who has no way to understand why you're using that to motivate them. We obviously want them to try to walk, but the motivation, if they never got there, is not to suggest that they have somehow failed or are less than anybody else. So going back again to this divide between disabled communities and medicine, I just want to remind you, there's a history here. Everyone, that's one, we have a lot of, I think, important things about our bioethics councils and how we do research with IOBs, but we don't pay attention to how easy it is to slip back into some of these ideas of an uber human or eugenic tendencies when it comes again to this idea that we used to have forced sterilization to make sure we weed out some disabilities from the population. We used to isolate and segregate. And even eugenics itself, which is really tied to the Germanic World War, the Germany eugenic propaganda was based off of US work to that time. So this is, again, something that everyone needs to take and understand. So again, disability as diversity, even to this day, even our diversity office, we are still working on how to understand that better. And a part of it is that disability is, yes, the nation's largest minority and the only one that people can join at any time, but that also is a part of it, that you sometimes have a large portion of people with disability that weren't disabled, and so they may not have any interest in identifying with that as a personality because of how society has biased them against disability. So they wouldn't want to go to a rally to support disability rights because they already don't want that label. Disability community is heterogeneous, and so in of itself, it is a diverse category. But that is why people with disabilities hold multiple identities at the same time, bringing us to the understanding of intersectionality, which I will cover. So this lack of disability efforts has also been pointed to, that disability is still a problem of accommodation rather than a difference to be celebrated. And I get back to this idealization of autonomy and independence. And autonomy is important, but understanding autonomy in a person who may have a cognitive deficit is a very important thought exercise. We just don't have to understand that dependence and powerlessness is somehow a negative when we reframe how our societies and communities support each other. And the other important point is the false equivalency of disability with lack of health. Disability and many types of disability can come with pain, can come with health comorbidity, but it in of itself, it is not a lack of health. So intersectionality just means that we can't continue, and I think you guys have probably worked on this with race and gender and class, but we cannot address these topics discreetly. And perhaps more importantly, when we think about intersectionality of individuals, that's very important. But we also have this understanding of almost like intersectionality of the social justice issues. So when, again, we come back to this, now I'm going to ask you to look at this again and now say, oh, now I know or learned a new fact. Don't just be aware of that fact, but really kind of kindle the fire of an intense need to explore why this is and what does it tell us? Well, it tells me that because physicians have a lot of interactions with people with disability, then we are more of a stakeholder in understanding poverty than we might think of because of that blue circle. And other social issues of today are in fact disability issues. So this is the work done by my colleague, Marianne Karishi, who we, again, kind of work together on a lot of this. But she has really helped me reframe how I think of especially capitalism, wealth inequality, and houselessness as it relates to disability. We have another triple Venn diagram where the tenets of ableism in the purple, how issues affect disabled people in the blue, and how other issues create new forms of disability and trauma in the green. And we see that all of these issues, except for climate catastrophe and endless wars, are really related to all three. And what I mean by that is, again, if you think about the whole reason my field exists, physical medicine and rehab grew out of the World War II. So endless wars sent home so many veterans with injuries and disabilities. That's why my field even exists, if you weren't aware. And then for the capitalism and wealth inequality, we're just seeing that create new forms of disability and trauma from depression and suicide. This is an article that I pulled recently just to say, this is about climate change. Dare to declare capitalism dead before it takes us all down. But I would almost also argue that we have to be more consistent about noticing why we do certain things in medicine because of capitalistic pull. Here's another one that's a book that specifically argues about how capitalism related to the suicides and overdoses and the opioid epidemic. And then this is also not new. The unruly rise of capitalism from the Hastings report in 1985, but which again, we're letting ourselves kind of slip into this, not exposing what it means. So here's an example, in my opinion, which is that capitalism is part of how medical providers get desensitized to people's personhood. Take the jubilance of the first year of medical school versus the jadedness of an overworked resident in their next to last or last year when they can't see the light at the end of the tunnel. And there's a lot of times a difference in that. Not everyone, but that is a desensitization that has occurred to why they got into this in the first place. And I feel that patients begin to lose their personhood because there's collateral damage in this system. And it's like as doctors, we're landlords who do not care for where a family goes when they're addicted. We just need to get them out of the hospital. Or you have a bounce back, God forbid that bounce back be a person who's it's a complicated disability. I've had residents round with me or be on my service and see my kids on good days on the outpatient side who say, wow, I've never seen a spastic quadriplegic look this happy because they've only ever seen them when they've been in the hospital. So again, now I'm going to ask you to ask yourself, if anyone here feels like they're still asking a question of, is this really an issue or is it an issue that I can do anything about? Now just consider if you might be denying the role of ableism in medicine. So I have found that when I talk to doctors about this, deflection or denial is the biggest issue. And I do this because I want to learn what I need to do to share, to get to a place, because I understand that we all took oaths. We are put all in this in for the right reason. We have got good heart and we don't have more time for diversity training. I get that. So, but the reality is that we are also at least subconsciously uncomfortable with situations where we are powerless to help cure, treat. And if it's not efficient how to help somebody, we say, go see somebody else. So now if I've convinced you and you did take the red pill and you're depressed, now I want to give you some tools. So now what? And so in parallel with acknowledging that there's been some denial and deflection, we now get to acknowledge and reject ableism. And as a community in healthcare, we need to Increased disability representation in healthcare, that gets back to that difference between who we let into med school versus who we try to keep as doctors even after they're disabled. And promote disability consciousness, not competence in medical education, training, and practice. And I'm not a medical education expert, so I got into this not really planning to create a medical student rotation because it's not on medical students to fix it. They're 10 years away from having leadership positions. We don't have 10 years to wait. At a minimum 10 years. I need to convince you guys and convince chairs and convince hospital admin to look at this. And so when I go through these, again, sorry with the clicking, go through with the disability representation in healthcare and consciousness, I'm going to say real quick with disability representation, that's a topic to come talk to me more about after. But there are things that we can and should be doing to get more people who from the beginning of their lives identify as disabled, or from the early part of their lives at least, after the formative years, because they tell us something about how we're doing this that can make it better for everyone, but especially patients. And then for the disability conscious medicine, we're going to wrap up and spend time on this before taking questions. But again, the paper that I think Dr. Spector sent out, where you can certainly go to, and I think it will flesh out some of the thoughts that we have for you. And I would really encourage people to come and talk to us. And I just want to highlight again that my co-authors, Adrian Dobridge and Marian Parisi, I couldn't have done this work without them. So I think it might come across as polished, but it was in no way like that by my own doing. Disability consciousness augments competency. So engagement with critical disability studies and disability theory is where we are trying to meld. And that is what I think is the bridge to the divide that we've been talking about. Disability studies is not even a minor that can be taken at many colleges across the world. There's usually 1 or 2 disability courses at least, but so it's not something that's really pervasive in the way that civil rights work or doing diversity, other general diversity work in your undergraduate curriculum. But for the School of Medicine, again, if you were to think about it as a medical set of goals, we might want to work on this competent the healthcare, about the disparities, of course, that's important. But again, recognize the role medicine playing in disabling, but then conversely enabling. And then recognizing that a disabled person's own experience is and expertise is a stakeholder that we need in training, practice, and research. And we're seeing more of that. I think if any of you have put in a research study recently that includes the aspect of a cohort of patients that may be disabled, there's more grants asking who on your research team is representing the stakeholder of the patients. And we're getting that input more, but not enough. And I want you to go back then, if you were to understand a good kind of point of what we can learn from critical disability studies, is looking back at intersectionality and understanding that ableism has been at some of the roots of many injustices and inequities that then even helped to understand how one group gets maybe injustices removed, but they've done that by distancing themselves from characteristics associated with disability. So everyone loves Rosie the Riveter, and we can do it as such an awesome tenet for women's rights. But what if you can't do it? Does that mean you're still less than? And the answer is no. And ableism is how slavery was really justified, in that understanding slaves couldn't take care of themselves. The plantation masters really doing them a service because they don't have the executive skills to run a life of their own. So, we're really helping them and just asking them to do some other work. That's ableism. And so even today, against citizenship for immigrants, a lot of that is understanding that they can't function in our society. So but again, disability competence is necessary but insufficient. So the individual curriculums only achieve a level of tolerance. And I say this because there's been 20 years of disability competence curriculum in the medical literature. And everything I've still been talking to you about, I hope has convinced you that we still have a problem. So we're still in this point of seeing disabled people and piteously. We're having a sense of charity and sadness and, oh, hope that doesn't happen to us. And this leads to these actions that might feel like mercy, that may in fact be violence and a breach of human rights to the patient. And that's especially related to the Michael Hickson case. You know, vital signs can be abnormal, but not people. I don't want to take away from the understanding that we need statistical relevance of certain things to tell us when to be worried about other things. But we got to remember how to get away from this understanding of a physical exam finding or a heart rate being abnormal, but a person being abnormal. Because that comes straight with the being accused of assigning a lesser value to those with disabilities. And so finally, I just want to make a comment that this is really how Dr. Spector and I really connected, is that I tell people to avoid altogether chief complaint medicine. And Dr. Spector made the great point of, what do you mean avoid? I teach all of my team to go back to tell me, what did the patient come here today for? Because they start off with telling me some study finding or a sleep study report. And I said, no, what is the patient in the room for? And that's extremely important. I don't mean to at all take away from understanding a patient's goal, but I want you to look at the language we use around chief complaints, and that we were taught a lot about chief complaints in medical school and residency, but we weren't taught about what other skills we should have. So this is, I Googled this slide from just taking from the first one I saw, and it said, you know, the chief complaint is why they're there, and it could be the presenting problem, and we want to get that answer verbatim. Great, but remember, this is capitalistic efficiency at work, trying to take what should be more natural conversation between two human beings and turn it into something that a person with maybe a high school degree can decide how complicated that conversation was. So you need to thought this, what type of HPI, how many elements, these elements are the classic location, duration, severity. You can do the status of two conditions. But where is the meaning here? Where is what's important to the patient once you've got past, yes, this is their goal. Now, how do I think about that goal? And that it works so good when someone comes in saying, I have a headache. Well, let's take that as the chief complaint and let's turn this into a visit today that we can do something for that patient. But how does that work if the patient says, what'd you come in for today? And they say, I have multiple sclerosis. And we say, no, what do you want me to do for you? Well, I have multiple sclerosis. I'm here because I have a complicated condition. Or you ask, what'd you come in today? And my child has spastic quadriplegia. Well, what do you want me to do for him today? Well, can you make him better with the flick of a hand? No, you can't. So how are you going to use this location, duration, severity idea? And again, with just looking at what you might be thinking subconsciously, if I were to do that with some of my patients, I would have 10 chief complaints, and I would have to code them in the way. I bill on time all the time. I don't even try to decode these things because my patients are not chief complainers. They're not problem producers. They are people. And so I have to know their goals. And just like me and Dr. Spector are on the same wavelength that we are not treating studies. We know their goals, but I don't think of how I'm going to code their story. That is the underpinning of an efficiently based system. There are other tools I use sometimes. One of them is the International Classification of Function, Disability, and Health. This is understanding that we have the health conditions and then the body structures impairment. And these two sections are where we live too much of our medical provider lives. I spend a lot of time on activity and participation that then, if you think of it as a coding system, I'm looking at not only how their gait is doing, but how that's affecting what they're trying to do with their adaptive sports, or what they want to do if they were to perchance want to be a Paralympic athlete, which I've had before. So this comes back into the social determinants of health on all three levels. So this is another system that is, we're nowhere near using this for coding in the US, but if we were to use it, I could be efficient with this and show the value of what I do in a different way other than time. So I want to again pause for questions. I'm proud. I left over 5 minutes, and I really appreciate everyone's time. And again, special thanks to my co-authors and colleagues here. I am going to stop sharing, and I haven't looked at the chat, and I don't know how you guys like to do questions. So just let me know. Oh, now I see the chat.
Yep, thank you very much. Why don't we start with Kim Johnson?
Do you want me to read your statement, Kim?
Usually they chime in unless they're on mute.
Okay.
Kim, you out there? Okay, how about Harry Gawanter?
Hi, thank you for this talk. I'm a pediatric rheumatologist and dad of.
I'm not hearing Harry very well. I don't know if you could get a little bit closer to your mic.
That's an issue for me too. Can you hear me better now?
Much better.
Thanks for this great talk. I'm a pediatric rheumatologist and dad of kids with disabilities. So this rings very true with me. And I guess the things I'd like you to comment is the current use by ICER of QALYs to determine value of our therapies, and the moral injury involved with having to defer to PBMs and everybody else for what we are trying to do for our patients.
Yeah, and I didn't hear the first part. Then I agree with your statement. I don't. Do you have a question there too about the moral injury part?
Well, no, I think part of it is for us to start thinking about moral injury as part of our thing. But I think the other part is the issue about the QALYs, QALYs by ICER, and determining what we are able to do for patients, or PBMs deciding, what treatments they think are better, and the implication of that upon our ability to treat our patients.
Of course, and I get back to recognizing their expertise. I tell my families all the time that I might be an expert on CP, but I'm not an expert on your CP. And so they really have to help me think about how this is affecting them. And about the quality of life, and again, I am still learning every single day, but one of the general trends that we see is that all of our research looks at quality of life that is health related, so HRQOL. That is only a small subsection of quality of life research. And so PubMed doesn't show you all the quality of life measures that are out there, because PubMed is a subsection of research. And so we think about what you might see on Web of Science and quality of life. And there are research studies that when you look at overall quality of life, that people with disabilities don't have lower quality of life by and large compared to anyone else. They might have slightly lower healthcare related quality of life. So if anyone's been Googling a PubMed, you'll find those, but that is a subset and an important understanding. So thank you, Harry. I think, who else now? Oh, Kim's ready, I think.
Yep, Kim's ready.
Yeah, thanks. I am a facilitator in the Cultural Determinants and Health Disparities course for the medical students. And I'd say that we do a section on disability and ableism. And during that section, one of the students who felt very strongly about this topic said that she did not like the fact that we say chief complaint at the
Yeah.
top of her notes, and that she'd like chief concern. And I found that, I really thought about that, and I thought that's true. And when I changed that in my note, it even reframes the way I see patients and families during the interaction. So I think that all the work that you're doing around language does mean a lot and does come up for us every day. So thank you for this talk.
Oh, I'm happy to do it. And I want critical feedback too, because I want to be able to know that if you've got things where you just don't think I've made a good point, it helps me so much if you'll tell me. I just want to make a statement on Tim Collins' chat then. Is that okay, Dr. O'Brien?
Oh, yeah, sure.
And Dr. Spector and I talked about that as well. This blaming patients for the health problems in general is at the base of a lot of other issues that we have with, and it's related to disability, because there's also a historical underpinning of disability being something that the gods cursed you with. So we're not that many hundreds of years away from that being the prevailing thought. So not only blaming for what you did do, blaming for what your ancestors did. So that's important. And Dr. Spector is right on cue there, that there is so much that is weighted on our current society's understanding of these conditions that we still need to, again, elevate. And I love the understanding that ableism is such an easy thing to try to use as an equalizer, but it leaves disability out. So when you talk about civil rights movements of we're just as strong as them, we're just as smart as them, for other groups getting their rights, that's not the only way to get rights. Other questions?
So
I know we're about at time.
With your permission, Christopher, I was just going to follow what you said.
Yeah.
There's this concept in psychology of the fundamental attribution error, and when you see bad things happen to other people, you assume it's because they did something wrong. But if bad things happen to you, it must be because of society or bad luck. And the opposite is true. If something good happens to me, it must be because I'm worthy and I'm deserving. If something good happens to someone else, well, they were lucky or society helped them or something. And this is a classic paradox in psychology that they talk about. And so we're really bad at assigning to ourselves all the ways that we're helped and all the ways that society hurts others. And so it's just it's a well-described phenomenon. And the other thing that you and I had talked about was this happiness research, right? Yeah. The idea that if someone asks you, if you acquired a certain disability, how would that affect your happiness? And people always say, oh, I would be unhappy or I would kill myself or all these things. But in reality, that's not what happens. And people who acquire a disability are not, like you said, their quality of life outside of specific that
they return to a state, like you said. Yeah.
Right. And people are very adaptable and they return to their baseline level of happiness after winning the lottery or acquiring a disability. There's just a narrow range where humans are set, and we return to that baseline. And we're very bad at predicting our future happiness based on future events.
Yep. Yeah. And I'm sorry I didn't get into my talk. I just didn't have enough time for everything. Any other final questions? And I can stay after a little bit if you want to do an official end, and then anyone that can straggle back can stay.
Well, thank you very much, Dr. Lunsford. That certainly gave us a lot to think about, and all the questions, I think, added to the importance of the message. If anyone has any extra questions, feel free to stay on, but I see people are heading off to clinic right now. But thank you very much.
Thank you all again.